Today we're going to talk about what factors alter respiration and change how respiration rate and depth, right? But I want, in the back of your head, I want you to think about what's the overall goal of the respiratory system. What's the overall goal? Move oxygen in and send off carbon dioxide. Okay? So the goal of the respiratory system, that's what it does. The changing of the respiratory rate is going to be altered to meet that goal. Okay, for whatever reason. And there's going to be a couple different inputs that will change, will need to be changed. All right? What happens if I don't have enough oxygen? Respiratory rate stay the same, go up or go down? What do you think? If you don't have enough oxygen in your blood, does respiratory rate go up, down, or stay the same? It'll go up, right? I need to get more oxygen in. What happens if I have too much carbon dioxide in the blood? Does it go up, down, or stay the same? It goes up. I need to get rid of carbon dioxide. Remember, keep the goal, the objective of the respiratory system is to bring oxygen in and get rid of carbon dioxide. Yes?
What would be an example of the respiratory rate going down?
What happens when you have a lot of oxygen? Your oxygen is like 98, 99%.
Do you just slow down your breathing?
Yes, your respiration rate goes down and it gets shallow. Think about when you sleep. Okay? All right, so today we're going to talk about the regulation of respiration, and it's controlled by the nervous system, right? It is mainly controlled by the nervous system. It is not really controlled, very little control of it related to the endocrine system, okay? But the goal is oxygen in, carbon dioxide out. And so those levels are in the blood and in other places are going to be responsible for altering the respiration rate. Okay? So overall, we can't make the lungs inflate anymore. So how the body regulates respiration rate is by sending information to the skeletal muscles that control respiration. That's the diaphragm, the external intercostal muscles through the phrenic and the intercostal nerves. The phrenic nerve innervates the diaphragm. Okay? The centers that control the rate and depth of respiration are found in the brainstem, in the medulla, and in the pons. Right? The medulla sets the rhythm. Right? So it's roughly 12 to 15 at rest, 12 to 15 breaths per minute. Right? That's set by the medulla. Okay? It contains the pacemaker and has a self-exciting inspiratory center. What does that know? What does that mean? Self-exciting inspiratory center. So, inspiratory means what? Inhale. All right? Self-exciting means it doesn't need any excitation or stimulus from the outside. So when you hold your breath, you hold it for a period of time, right? Yes? But at some point, what do you get? If you held your breath for a period of time, and I told you, hold your breath as long as you can, tell me how it feels. Tell me how it feels.
Tight.
It gets tight, right? Then you continue, and it feels like what? So you've been in the pool, right? And you're like, as a kid, who can hold their breath the longest? What do you do? After you get this urge, right? It gets stronger and stronger and stronger to breathe in. Yes? That's the self-exciting inspiratory center. At some point, you're going to go and breathe and inhale. Okay? Because your body is going to tell you, you gotta do this, and eventually it happens. And in very few cases, you can't override that. There are some cases that some people will voluntarily continue to stay over that, and then they pass out, and then guess what happens? They start to breathe again on their own anyways. Okay? So it happens, and it's like self fulfilling, okay, on its own. And then the pons smooths out the respiration, so it's not in out, herky-jerky. It's in, right, to a certain point and nice and down, smooth, okay? So these are autonomic nuclei. What does that mean? What part of the nervous system controls them? Autonomic nuclei means what? Autonomic nervous system, right? So parasympathetic and sympathetic nervous system, right? Your respiratory center is in the brainstem. You have two parts within the medulla respiratory group, one on the ventral side, one on the dorsal side, all right? So the ventral is on the anterior medulla, and the dorsal is on the posterior medulla. And then the pontine respiratory center is known as the pneumotaxic center, okay? So these neurons, what do? Right? Some of them, they synapse or they stimulate what? Skeletal muscles, right? They stimulate skeletal muscles, right? And other respiratory muscles. Because that's what's going to control you opening, right? That contraction of the diaphragm will lead to the opening of the lungs, right? Increased volume, air comes in. Okay? So, the ventral respiratory group synapse with the lower neurons of the skeletal muscles of the spinal cord. Those neurons then project to the respiratory muscles. So, we just kind of go from one to another, right? Eventually innervating the diaphragm and the intercostal muscles. What are the two main muscles of respiration? The diaphragm and the intercostal muscles. Those are the ones that will open up the chest. Oh. So, neural regulation. Normal respiration is about 12 to 15 respirations per minute. That is called eupnea, right? That is normal, regular breathing, okay? Hyperpnea is faster than normal breathing, an increased respiration rate due to extra oxygen needs. What would be some examples of extra oxygen needs? Exercise, fever, elevated body temperature, okay? Would be anything increase in metabolism, would increase body temperature, would increase your needs for oxygen. Your cells need more oxygen, and so you have to deliver it faster, okay? Apnea is the absence of breathing. Where have you heard of apnea before? Sleep apnea. Okay, so that's a periodic cessation of breathing, right? And so sleep apnea happens when you're sleeping, and then you suddenly kind of like the self-stimulating center says, wake up, you're not breathing, dumbass. Boom, you wake up, and your body, you don't actually wake up out of like conscious sleep, but you come out of deep sleep, and then it leads to problems with sleeping as it accumulates over time. Okay, and dyspnea is difficulty or dysfunctional breathing. Okay, give me an example of someone who exhibits or experiences dyspnea. Asthmatics, right? Someone with emphysema, chronic obstructive pulmonary disease, bronchitis, right? Are all examples you see dyspnea or abnormal difficulty breathing. Okay, so here is a basic schematic. What did I tell you? What's the role of the respiratory system? To do what? Bring in oxygen and get out of carbon dioxide. So if you look at this picture, oxygen sensor and then carbon dioxide sensor. Does that make sense? So those are the two gases that we need to move in and out. So those are going to be the two substances and molecules that we continually measure or regulate and identify so that if there's any changes, the respiration rate changes. Okay? So first, let's look at oxygen. Oxygen sensors in the aortic body and the aortic arch. So there are chemical chemoreceptors, you'll see that in a second, right? These are receptors inside that part of the heart, of the blood vessel, outside the heart, okay, that will consistently measure the levels of oxygen in the blood. Why right there? Why not in the abdominal aorta? Why not in the femoral artery? Why not in the axillary artery? Why in the aortic arch? Blood entering the aortic arch comes from where?
It's oxygenated blood.
It's oxygenated blood. It's come from the lungs, through the pulmonary veins, through the left ventricle, through the aortic valve, and is in the aorta right there. So it has come out of the heart, and that is the blood that has the highest amount of oxygen that it's there, right? There's no branches that have happened. Maybe some has come off and gone to the heart, and then some of it is going to branch off and go right to the brain. So right there is the best place to consistently measure the amount of oxygen to identify when there's drops as fast as possible. Does that make sense? Okay. The other gas, right, carbon dioxide, increases in the blood, okay? But we don't have a chemoreceptor for carbon dioxide in the blood, okay? Instead, there's a chemoreceptor for carbon dioxide in the cerebral spinal fluid of the brain, okay? So it's a little bit different. But we know blood goes to the brain, right? And if CO2 and plasma, that the cerebral spinal fluid, if you recall from last semester, from Bio 211, right? Cerebral spinal fluid is mixed. It kind of goes back through the plexuses and the dural sinuses of the brain, and that is where CSF is exchanged, where CO2 is exchanged between the cerebral spinal fluid and the blood. Does that make sense? Okay, so cerebral spinal fluid will exchange carbon dioxide with the venous blood, and then it empties out. Okay, that's the way it should go. So ideally, carbon dioxide should not build up in the cerebral spinal fluid. It should always be transferred to the venous blood as it exits the brain. Does that make sense? Yes? But if we can't get rid of it enough, CO2 builds up in the brain, and then that will then trigger the brain to send impulses and increase respiration rate. Okay? Because due to a drop in the pH of cerebral spinal fluid. We'll see that in a second. So the two major gases, the goal of the respiratory system, are how we measure changes in respiration rate. So those inputs go through to the medulla, and then to the medulla and the pons, and that goes out to the muscles. The effectors are the skeletal muscles, the diaphragm, and the intercostal muscles, and increase respiration. Okay? Same picture. This is actually just from your actual text. Okay? Non-neural factors influence rate and depth, right? Increased body temperature, fever through the hypothalamus, right? So body temperature goes up, metabolic needs go up. That then can lead to increased respiration. Exercise, that we talked about, okay? Talking, that's a volition, that's voluntary. Coughing is involuntary. It's due to reaction to the presence of particulate matter or something, or sickness clearing out, right? But that is a non-respiratory change, right? It has nothing to do with the gas exchange that's occurring. Does that make sense? Right? So even exercise increases rate, but it's not because we have too much oxygen or not enough carbon dioxide or vice versa. It's just because our bodies need something else. Okay? Volition, obviously we can voluntarily control, hold your breath or breathe up and down. right? Breathe in and out faster, right? That goes through the frontal lobe. And then emotional factors, crying, laughing, alter respiration rate. So the non-neural factors that influence respiratory rate and depth, right? The chemical factors, carbon dioxide levels, okay? So carbon dioxide and the other is going to be, what's the other chemical we're going to be looking at? Carbon dioxide and oxygen, okay? So the increasing carbon dioxide and the body's need to get rid of carbon dioxide is the most important stimulus in regulating respiration rate and depth, right? Secondary is oxygen. So as carbon dioxide levels increase, what happens to blood pH? Because carbon dioxide is transported throughout the body in the blood, right? Dissolved in plasma in the form of what? What is most carbon dioxide transported as? Carbonic acid, which then transfers into bicarbonate ion, okay? So if I build up CO2 though, that shifts that equation and pH goes down. So if CO2 goes up, that shifts the equation and that actually lowers pH, becomes more acidic. Does that make sense? Okay? And then when CO2 goes down, we get more basic. Okay? So, to that end, if CO2 levels in the blood go up, what do we want to do? Increase the rate and depth of breathing to get rid of carbon dioxide. Okay? These carbon dioxide works directly on the medulla, on the respiratory centers of the medulla to help control and regulate respiration. But CO2 is the most important stimulus. Okay? So, we have chemical receptors for CO2 and oxygen, and then likewise, because CO2, as CO2 builds up, it alters the pH of blood, right? We just said that. So CO2 levels go up, pH goes down, becomes too acidic. And pH is a measurement of hydrogen ions in the blood. Okay? So the three molecules we're actually going to monitor are going to be oxygen, carbon dioxide, and hydrogen ions. Okay? First off, carbon dioxide. The receptors for carbon dioxide are going to be where? Where did I say it built up? In the cerebral spinal fluid. So those central chemical receptors, chemoreceptors, are found in the medulla, and they monitor CSF. Don't forget, CSF flows through the brain and around it and around and over it. So even in the medulla, CSF is monitored. Okay? Those receptors are present there. As carbon dioxide builds up, the pH changes. Okay? CO2 usually diffuses from the blood to CSF where carbonic anhydrase is. Carbonic anhydrase, we've heard that enzyme before. Okay? It builds carbonic acid from carbon dioxide and water. So as this builds up, what happens? We end up with more of this. Okay? And then that splits into H plus HCO3. Right? So if we get more of CO2, we get more of that, then we get more of this. What happens? More hydrogen ions leads to lower pH. Do we understand? Do we follow that? Yes? Questions? So normally, CO2 from the cerebral spinal fluid should diffuse from the cerebral spinal fluid into the venous blood and then out. Okay? But if that If that is backed up because I have so much in the blood, it's going to lead to more in the cerebral spinal fluid, changes the pH, and then that alters, that is the stimulus for increasing respiration rate. So that then CO2 levels eventually will go down in the blood, CO2 will diffuse out of the CSF, and then will bring pH back up to normal. Okay? Other receptors that are involved that also influence respiration. We have proprioceptors. These are, proprioception is the awareness of your body in space. Knowing that I'm standing up, I'm laying down, I'm whatever your body's doing, okay? So muscles and joints are stimulated by body movements. Laying down on your back versus rolling over on your stomach while you're sleeping. That alters your respiration rate for a slight short period of time. Baroreceptors. These are pressure receptors, okay? In the pleurae, that's the pleural membranes, and in the bronchioles, they respond to stretch, right? The more they're stretched, the easier it is, right? Or they're not stretched, they can move air in and out. Okay, and then we have irritant receptors in the air passageways, which will respond to, particulate matter that's been inhaled and cause you to cough and sneeze, et cetera, to remove material out, right? And that alters your respiration, but that's not necessarily directly related to gas exchange. Are we clear? Okay, so a couple different receptors, but not aside from oxygen and carbon dioxide. All right, so what's the most important stimulus in regulating respiration rate and depth? Carbon dioxide levels, right? And then secondary to that is oxygen, okay? Changes in oxygen concentration in the blood are detected by these chemoreceptors in the aorta, we just talked about, and here's the other one, the common carotid artery. Why the common carotid artery? Why is that particular one important? Give someone else an opportunity. It goes to the brain, right? So think about it. The aorta, blood's coming out, and right off the aorta, blood goes right to the coronary arteries to the heart. Yes? Second, the common carotid branches right off of the aorta or off the brachiocephalic artery, right? Goes to the brain. What two organs do you absolutely have to have for life? Brain function and heart. Absolutely necessary, right? You could actually stop breathing for a period of time and still live. Yes? Okay. So we want to maintain high levels of oxygen going to those areas. Okay? And so these are stimulated by changes in hydrogen ion concentration. Okay? Or respiratory gases in the blood. Okay? And so they actually respond to hydrogen ion concentrations that are separate from what we just talked about with carbon dioxide. Okay? So the carbon dioxide builds up, hydrogen ion builds up in the cerebrospinal fluid. That's not the same stimulus that we're talking about here, right? So something else has to happen. Whether we have some problems with fluid intake or kidney issues, that could cause a change in blood pH, and that's what will change respiration rate through this system. That would be separate from what we see in the cerebrospinal fluid. All right, so there's actually two avenues that hydrogen ions can cause that. All right, and this information sets the medulla and influences respiration rate and depth. Okay, so how this works, the stimulus are sent to the dorsal respiratory group, which then are relayed to the ventral respiratory group, and then that triggers changes in rhythm and force. Those changes alter the amount of time in inspiration and expiration, and then some depth changes as well. So, ventilation increases in response to detecting increase in hydrogen ion concentration in the CSF. Remember, increased CO2 leads to a decrease in pH, which is equal to an increase in that. So, to get rid of the excess carbon dioxide, ventilation increases. More air moves in faster and out, hopefully to get rid of more CO2. Okay? Also, peripheral chemoreceptors detecting an increase in blood pH or the increase in CO2. Both of these are also going to be related because we know CO2 in the blood is converted to bicarbonate ion through carbonic acid. So if I have more CO2 in the blood, it's going to lead to more carbonic acid and actually will increase hydrogen ion concentration. Okay? The point being, increased ventilation expels more CO2 and returns conditions to normal. If the conditions were reversed, if we had decreases in hydrogen ions or decreases in carbon dioxide, ventilation slows down. Right? Think about what happens. If I have not enough CO2 in the blood, well, I can slow down. I don't need to move air in and out very much. I need to build it back up. I don't want to have too little CO2 because if I have too little, then the pH becomes too high and it's not in the optimal range. Okay? So those changes or fluctuations in blood pH in response to changes in respiration are what we call respiratory acidosis and respiratory alkalosis. We'll talk about those in a little bit. Okay? So, hyperventilation and hypoventilation. You've heard of hyperventilation, right? I'm sure you've all heard, I'm having feelings of anxiety and I'm hyperventilating. Hyperventilation is the breathing rate or depth above a body's demand. So if I'm breathing more than I need to, in and out, think about it, more than my body needs, okay? It's not that I was doing exercise and I expended a bunch of oxygen and now I'm breathing faster or deeper because my body needs oxygen. No, my body has enough oxygen. I'm just breathing more than I need to. What are you doing? Are you loading more oxygen in your blood? No, your body doesn't need it. You're at 98%. You're not going to get any more. But what are you doing? By breathing more, you are still going to take off and blow off carbon dioxide. Does that make sense? So you're skewing the balance by pushing out and getting rid of more carbon dioxide than you need to. Okay? So what happens? Oxygen rises because you're putting, but carbon dioxide falls. All right? Additional blood, oxygen doesn't enter the blood, but there's a greater loss of CO2 from the blood. And this is called hypocapnia. Hypo means low, capnia refers to CO2. If I have low CO2, what's going to happen to blood pH? It's going to go up. Okay? And that's what it's called respiratory alkalosis.
So hyperventilation can turn to...
Yes. Right? Hyperventilation could be a good thing, though. In what case might you hyperventilate that could be physiologically necessary? If you have too much CO2, respiration rate goes up, and you need to get rid of it more. That is what you could do for hyperventilation, right? Hyperventilation is functionally useful in that case. Okay, so low blood. So now with hyperventilating, right? Oh man, and CO2's dropping in the blood. Well, low CO2 causes vasoconstriction, right? And it can actually lead to brain vessel constriction, right? It may decrease blood hydrogen ion concentration, what we just talked about, right? There's your respiratory alkalosis. Over time, because you're hyperventilating, and those blood is constricting, and now blood pH changes, you get faint, dizziness, numbness, tingling, cramps, tetany, right? If prolonged, it could lead to loss of consciousness, coma, and possibly death, right? Most of the time, 98% of the time, loss of consciousness kind of like is the reset button, and things kind of reset from there. How can you, what is one way that you can help when someone's hyperventilating? No. Stopping is just, you can't just tell them to stop. And no, smacking them is not going to work either. What's the common treatment for someone who's hyperventilating? Breathe into a paper bag. How does that work? Well, breathing into a paper bag, okay, in and out. Now, the air that's expelled stays in the bag, and then it's inhaled back in. Okay? Does that make sense? So now the air coming back in has not as high oxygen. It actually has a higher CO2 level, and it tricks the brain into slowing down. So now the air that's coming in, you don't have enough oxygen to load in, but then CO2 isn't coming from the blood into the alveoli as well because it's building up in the air you're breathing in. The brain kind of like slows down. Okay? So could be hyperventilation could be a response to acidosis. Acidosis means you have increased CO2, and then increased CO2 leads to low blood pH. So if I get rid of the CO2, pH will come back up to normal. Okay? Eventually, the goal is to blow off the CO2 to restore normal blood pH. Hypoventilation is the opposite, lower than normal ventilation rate, right? Breathing too slow, which is called bradypnea, or too shallow, hypopnea. These causes include obstruction, right? Choking. Pneumonia, which leads to obstruction as well. Brainstem injuries, right? And other respiratory conditions. Emphysema, lung cancer, chronic obstructive pulmonary disorder, bronchitis, you name it, right? Hypoventilation, not getting enough air in. So if I don't get enough air in, what happens to oxygen levels? They drop. What happens to carbon dioxide levels? They increase. High oxygen levels, high CO2 levels means low pH, and now we have respiratory acidosis. All right, so then we end up with increased carbon dioxide in the blood. That's hypercapnia, and the low levels of oxygen in the blood. That means that oxygen is not going to be delivered to tissues. Then you end up with what's called a hypoxic condition. Hypoxia is low oxygen levels in the blood and low levels that are being delivered to the tissues. All right, so actually, hypoxemia is low oxygen in the blood. Hypoxia is low oxygen in tissues. Okay, so hypoxia is problematic because then we're not getting enough oxygen to the brain, to the heart, to muscles, etc. Right, and that's directly related to what the levels are in the blood. What's the response to hypoventilation? Well, there's going to be ways to kind of like increase breath rate and death. Okay, so this hypoventilation may result in inadequate oxygen delivery. Could be for increased hydrogen ion concentration, so it might result in respiratory acidosis. It could cause lethargy, right? You're lethargic, tired, sleepiness, headache. Polycythemia. What's polycythemia? Anyone know? Polycythemia is the increased amount of red blood cells, immature red blood cells in the body. Why would you produce polycythemia in response to hypoventilation?
Like, the red blood cells, they carry oxygen
Mhm.
in hemoglobin, so then, since you're not getting as much oxygen to the tissues, your body's gonna think to, produce more red blood cells.
Yep. You guys follow that? So the function of red blood cells is to carry oxygen delivered to tissues. But if I don't have enough, the body doesn't have as much or has a lowered amount of oxygen on the red blood cells, the body doesn't know the body doesn't know it's not because we don't have enough red blood cells. It just knows it has low oxygen. Okay? So the kidneys recognize that, release erythropoietin, and stimulate the body to produce more red blood cells. And they do it faster, so they end up being immature. You end up with the polycythemia. That's the cause of it. Okay? And then cyanotic tissues. What's cyanosis? Taylor.
When the skin turns
Right? The tissue of the skin has a bluish tinge, and that's usually indicative of hypoxic conditions. Okay? If prolonged, convulsions, loss of consciousness, and possible death. So hypoventilation is a response to when blood pH is above 7.5, right? Which is also called alkalosis. So alkalosis is low CO2, which leads to a high pH, right? So how is breathing slowly a response to that? If I slow down the breathing, I retain carbon dioxide, right? Carbon dioxide is not getting blown off. It stays in the blood. It builds up in the blood. Then this then works to counteract that stimulus. Low CO2 levels, we're working to bring it back up. CO2 levels go back to normal, pH goes back to normal, and then we're happy as can be. Okay? So the respiratory system works direct in conjunction with the cardiovascular system to help regulate oxygen, carbon dioxide, and indirectly hydrogen ion concentration in the blood, and then eventually into the body tissues. Breathing and exercise, right? I think this is kind of like the most intuitive thing. We've all exercised. We've all felt the feeling of being out of breath or short of breath from doing some type of intense exercise. So as exercising, breathing shows hyperpnea to meet increased tissue needs. More oxygen being utilized, more oxygen needs to be delivered, right? Depth increases, but breathing rate remains relatively stable, right? It might go up a little bit faster, okay? But most of the time it stays within a normal range, but your depth gets bigger. So you're moving more air in and out in normal breaths, okay? The goal of increased respiration for exercise is that the levels of oxygen and carbon dioxide try to keep them relatively stable, okay, even when skeletal muscles are utilizing oxygen, okay? So your increased cellular respiration is met by increased depth of breathing, increased cardiac output, right, and greater blood flow through vasodilation, okay? And then from there, you can end up, what are the signals that cause that, right? So you have proprioceptive sensory signals, so response to movement. So you think about, all right, I'm gonna move, I'm running, going for a run. All right, you got that breath down. That's meant for your body moving, and your body's, like the movement of your body actually starts to influence the rhythm of your respiration rate, okay? Corollary motor output from the cerebral cortex, and then conscious anticipation of exercise. Think about, you've seen, last summer was the Olympics, right? Summer Olympics, yeah? We've seen the, sprinters, they start to get all limbered up, right? And then they see their breath changes, right? So they're consciously thinking about what they're about to do, and their respiration rate is influenced by that. Questions on the factors that are involved in controlling respiration rate and depth, what hyperventilation is, hypoventilation, as well as respiratory alkalosis, respiratory acidosis. Think about the relationships, okay? And if you think about it in terms of what the goal is, maintain a certain level of oxygen, maintain a certain level of carbon dioxide, and if I shift the balance one way or the other, how is that going to what's the outcome of that? Okay, if you can do that, then you're in a good shape for understanding the questions that will be posed to you. Okay? So last part of the chapter of the system is respiratory disorders, because they're prominent and we have a growing geriatric population. We have increased incidence of especially these things called a group of disorders called chronic obstructive pulmonary disorders, right? Emphysema, chronic bronchitis are COPD, okay? So they're grouped together. They used to be separate, but now they're grouped together, right? We've all seen the commercials for COPD as, for pharmaceutical commercials about how to treat this and what it means, right? And this is a major cause of mortality and morbidity in the United States, as well as disability, okay? So what are these two? Features: obstruction, right? Chronic obstructive pulmonary disorders. There's something in the way that's obstructing the airway in some way. Either gas exchange is being obstructed, or the air getting to the alveoli is being obstructed. Okay? So that's the kind of all together. Almost always there's a history of smoking, right? Or some type of pollution. Maybe it's coal dust, or smoking, or working with asbestos, or whatever it might be. Okay, but most of the time it's associated with smoking. They are symptomatic with labored breathing or dyspnea, which becomes progressively more severe over time. Okay, coughing and frequent pulmonary infections, right? Because of the obstruction, whether it be from a bronchioles being constricted or something stuck, there's buildup of mucus and infections become more common. Most victims or most patients are hypoxic, meaning they have lowered oxygen levels in tissues. They retain carbon dioxide, right? And because they're retaining carbon dioxide, they exhibit respiratory acidosis, okay? Ultimately, they will develop respiratory failure, right? That's going to be the ultimate outcome, right? And it's, again, progressively severe over time, right? And it could be a year, it could be 40 years, depending upon how the severity of the disease. So let's look at two of them. One is chronic bronchitis, right? Bronchitis is what? Inflammation of the bronchi. So the larger airway passages of the lungs, okay? The mucosa of the lower respiratory tract becomes severely inflamed, all right? So inflammation builds. What does that do for the size of the airway? It's restricted. Mucus builds up because of the inflammation. The pooled mucus impairs ventilation. So air doesn't move in as well. And as a result of that, more mucus actually impairs gas exchange. Okay? More mucus, which is pooling, leads to increased infection. And pneumonia ends up being a common result. Okay? These individuals are called blue bloaters because they are they are retaining CO2, right? They are cyanotic, so they're blue, right? They're hypoxic condition. So they're bluish tinge, and they're bloated because they want to. They're bloated. They want to get rid of or try to get rid of the excess carbon dioxide, but because of the passageways, they can't. Air gets stuck in the airways. Okay? But we still end up being hypoxic in the end. The other common COPD disorder is emphysema. Okay? And Emphysema is not related to the bronchi, but more the alveoli. The alveoli enlarge due to the particulate matter and junk that's there. The chambers between alveoli break, causing inflammation, and leads to lung fibrosis. Fibrosis is lack of stretchiness. Gets stiff, okay? And as this happens, because they get stiff and they can't stay open, the airways actually close during expiration. So as the airways close, what happens? The air that's not being expired, right, that's like, say, lower than the closure or the blockage, gets trapped. So patients have to use a lot of energy to push the air out. Forced expiration on every exhalation rather than the passive process that is expiration. Okay? So, because of the retained air, the chest becomes overinflated and you end up with like this kind of like barrel chest. They kind of look like this because there always has more residual volume. Okay? And they're called pink puffers because they're trying to blow out the air to move it out in order to replace it with the new stuff. Okay? Cyanosis, in this case, appears late in the disease. Because remember, we have a higher amount capacity of to retain and move oxygen even with the trapped air that's in there. Right? So we can still deliver oxygen to the tissues, but we want to blow off the CO2, and that's not going to move as well as normal in this case. Okay? And again, it's a progressive disease. Eventually leads to obstruction. That's why it's called chronic obstructive pulmonary disorder. Right? Dysfunctional breathing, frequent infections. Eventually, it leads to respiratory failure. Treatments include, you're just treating the symptoms, right? You increase steroids that go in or albuterol inhalations that will work to open the bronchioles and move air in, but you really can't get rid of the tar or the particulate matter that's covering the alveoli. Once the alveoli break, there's no rescuing them or getting new ones. So your gas exchange is disrupted, and it leads to years and years of disability and problems over time, eventually leading to respiratory failure and death. Questions?